Hi everybody, hopefully you guys can hear me okay. We'll begin in about just 1 minute. We're just waiting as a couple other people join. Just a note that if you can't hear me or if you can't see the slides, you can simply try refreshing your browser. That should, if you have any issues throughout the webinar, you can just do that and hopefully that will help. All right, I think we'll get started just to be mindful of time. Hi everybody, my name is Nicole Cork. I am the Association Manager of iHEA's activities. Welcome and thank you for registering for today's webinar, Estimating the Costs of COVID-19, Health Systems, Households, and Opportunity Costs, which was made possible by a grant provided by the International Development Research Center. Today's webinar is being translated from English to French. So if you prefer to listen in French, we encourage you to adjust your language at the bottom of the screen. The webinar will run for approximately 60 minutes, and we are recording it to upload it to our website in both languages afterwards. Before we begin, I just wanted to run through a couple of housekeeping items. If you do experience any technical issues during today's webinar, you can contact technical support by clicking on the question mark on the bottom left of the screen, or if you are using the mobile app, you can click on the menu bar to access it. Everyone on the line is muted except for the speakers, and you won't be able to unmute yourself. So please use the chat box on the bottom of the screen for any questions or comments during the webinar, and they will be addressed at the end. Finally, we will be sending a brief survey out following the webinar, and we do encourage everyone to complete this, as it is important in terms of offering future multilingual webinars. I'm now going to pass it over to our moderator, Kara Hansen, who will be introducing today's speaker.
Good afternoon, everybody. So I'm Kara Hansen. I'm from the London School of Hygiene and Tropical Medicine, and I am a professor of health economics, and I'm Dean of the Faculty of Public Health and Policy. So I'm really pleased today to be able to introduce the speaker, who is actually from my own institution, Professor Anna Vassal, who is in the Department of Global Health and Development, and she's also Director of the Centre for Health Economics in London. She spent, unlike many of us, she spent time in the real world. So she worked for 20 years as a professional economist, working both in the UK and in a variety of low and middle income countries, supporting the use of economics in planning at both healthcare provider and national levels. She's been at the School of Hygiene for 10 years, focusing on the economics of infectious disease, sexual and reproductive health, and the prevention of gender-based violence. She's a co-PI of the TB-MAC Modeling Consortium, and she's published widely on the economic evaluation of TB. She's also very involved in supporting the use of economic evidence in priority setting as part of the Disease Control Priorities Project. So she's also bringing to today's seminar her experience in looking at the costs, health, and economic impacts of COVID-19. And one of the projects through which she's doing that is a project that's funded by Wellcome and UK Aid, looking at the impacts globally. So the plan is that she will speak for probably about 25 to 30 minutes, and then she'll hand back over to me to help moderate questions. So as Nicole said, if you can put your questions in the chat, you won't be able to ask them, but I will ask them for you, and I'll, as much as possible, kind of group them into themes. So without taking more of your time, let me hand over to Anna to start her talk.
I hope I'll try and speak as loudly and as clearly as I can. And for some of you who know me, you know I normally speak quite quickly, but this is being translated, so I will attempt to speak quite slowly. So I'm going to talk today about how to estimate the costs of COVID-19 and from a variety of different perspectives, from the health systems, household, but also as always, an economist reflecting on opportunity costs. This work that I'm going to present actually reflects the work of a large number of people who I've listed there. We've been using data from previous projects, including the Value TB project, so very much starting this work, taking existing work we've done for TB and employing it to estimate the costs of COVID. So I just want to start with a few general comments before I get into the specifics of costing, the details of COVID. When I started sort of thinking about this was very early on, maybe even January, February of this year, being made aware of what was coming by the modelers who were working at the London School. And I started to think, well, shouldn't we try and estimate the cost so we can inform ministries of health, but also donors and development partners to prepare and to organise funding to support what was going to happen. When I started talking about this, many people who I talked to said, well, there's almost no point because as this hits, costs will not be important, and all that will matter is that we can save lives and people will be prepared to spend what it takes. To some extent, things have changed. Some of the things which are different and we have seen happen is that more money is being spent on health sectors in some countries, but that still has opportunity costs for other sectors. That money is still taken from somewhere. We've also seen in some countries bringing forward their consumption, future consumption, to spend money now. I think that's happening in many countries, so that has also changed. And we're also seeing shifts in the burden of costs between households and governments. And all these shifts are taking place under a huge amount of uncertainty and at time horizons that none of us are familiar with or used to. Having said that, there are many things that remain the same from things that we were doing before when we were looking at costs, and particularly opportunity costs, and these have not gone away. There are still opportunity costs in the health sector, so all those who said initially the health sector will just get extra money and be able to absorb this are now being seen, the difficulties are now being seen as the health sectors around the world are trying to scale up, and the impact on other services, not just because of rules about infection, but also about limited resources. And health sectors have needed to plan, estimate budget impacts and mobilize resources in a way that we haven't seen in the past, and costing information is an important part of that process and remains so. Finally, we're at the beginning of people exploring the potential of new technologies, and hopefully new technologies will emerge that help us deal with the consequences of COVID. And we will still need economic evaluation and costing to help us set appropriate prices for those new technologies, which also, even if the normal rules of how we decide on those technologies change because we incorporate wider societal impacts, those costs will still have opportunity costs, even if they don't all fall on the health sector. So I think as health economists, we do have to change the way we're doing things, but also we have a huge body of experience in both planning and costing and our economic evaluation tools that can support governments make their decisions. The other thing, broad picture question I wanted to address before really getting into the nitty-gritty is often costs are considered very boring by health economists. There are many, many more exciting areas to work on, and I think and perhaps even costs should be left to accountants and not economists. I was very pleased to see a presentation by my colleague Catherine Pitt to the Impact Evaluation Network, and a recognition that this kind of data remains important, particularly when we're working in health systems which don't have the mechanisms to sort of estimate costs as they're being incurred. So I think as economists, it remains important for us to measure and understand costs and to understand how they change as policy changes and how health providers react to different incentives and how they change as technology changes. I also think it's important that the scientific community, although costing is often seen as something that's more for professional economists or consultants, we have a huge depth of experience to bring to costing in terms of our understanding of what is good data and high quality data, and understand biases and issues of precision and those issues which are often not brought to bear when we're making cost estimates. So those are two sort of general introductions as into why I think it is important to spend time thinking about how and costing and how we cost COVID. So I am going to do the policymaker's trick of jumping straight to the results, but then come back and talking a little bit about the methods, challenges we faced in coming to these results. Now, the first thing I should say is the results I'm going to present are very early results. They're the first stage in a set of results. So what I'm showing here are very first estimates of the cost of an unmitigated epidemic. So these are not predictions, if you like, of the current cost of the current situation. That's something we're in the process of developing and adjusting this model for. But nevertheless, we felt it was important to emphasize that there are many costs associated with illness and associated with COVID itself before we consider the cost of intervention, and particularly as we do in economic evaluation, to point out that the comparator is an unmitigated epidemic. We are not simply just looking at the cost of interventions, but we have to look at the incremental cost of intervention into COVID and consider that COVID itself has huge costs. These estimates as well, in terms of being an unmitigated epidemic, are not just assuming no government response, but also unrealistically no household response. It's not that we rely on government policy to protect ourselves. It's more that governments interact with our own choices. And this assumes that, if you like, business as usual, that we do not as individuals start to protect ourselves and incur extra costs in doing so. So just to be very clear on what I'm going to present. So if you've been following the epidemiological model projections of COVID, you'll see that to date, most modeling groups have focused on the bottom half of this graph. So what you see here are estimates of the bed capacity required as you hit the peak of an unmitigated epidemic and its intensive care unit bed capacity. And as you see, this is for 5 different cities. We've modeled that for sort of 2 sets of broad scenarios. One where it's the sort of WHO recommendations on bed usage, assuming a perfect level of care, and on the right-hand side are estimates of what would happen under very busy conditions under a surge. And then in a different, the sort of whole block of pink and the whole block of green also are divided into different blocks on assumptions of severity. And one of the key uncertainties we have at the moment is understanding what percentage of cases become severe in different population groups, considering comorbidities. It was great to see yesterday publications from South Africa on how HIV and TB may impact COVID, but as yet, for many populations, we have little, indication of all the risk factors and the levels of severity. So the 100% severity is our best estimate at the moment, but we also looked at what happened if there was less, half the severity, or 150% of our best estimate. So just to explain the graph. What you see here is clearly, as in many countries, ICU capacity is completely overrun during a peak, but sort of working or listening to Edwin Barata from KEMRI and others, we also really wanted to look at general bed capacity and understand what would happen, would the peak also breach general bed capacity. And that's the top part of the graph, which so far has not been done in many settings. We didn't, just a small point, we didn't draw a line across this graph. We have this kind of shaded area of current capacity, because this sort of bar is representing 100% capacity, but we had long discussions about what is real capacity. Is oxygen available on these beds of the right type? And also what beds would really, what were the other essential services that would still require beds? So we just left this area shaded, and the reality could be anywhere between sort of 0 and 100% of this. So that's one of our first estimates leading up to the cost. The other thing we looked at, which again is slightly different than it's done before, is we looked at healthcare worker capacity, and these figures follow the same principles, but what you see here is, along with ICU bed capacity, the situation is quite, drastic or severe for healthcare worker capacity. We really wanted to make the point that looking at ICU beds is a sort of insufficient characterization of the limits of health systems, and actually they're facing many more limits, and one of the most severe is healthcare workers. So here we try to illustrate that how in excess the peak would be compared to current healthcare worker capacity. We then used what we'd done there and sort of extended it to look at financial implications and economic costs. So on the left-hand side of this block, we looked at health sector costs, again linking to the epidemiological models of an unmitigated epidemic in each of those cities, estimating the costs of different parts of public health interventions, testing and treatment. We used cost data, as I say, from a previous study we'd done in collaboration with 5 countries from TB to estimate these costs, adjusting them and also adding in different costs from COVID and searching the ICU sort of costing literature to extend our costs in different ways. So we took the basis of value TB and then extended using other data. We also worked with 3 of the countries to validate the estimates in terms of expert opinion, and we're particularly thankful to have in-depth engagement from Pakistan, who were planning and costing their response at this time, so could really provide us with detailed price data. These figures are cost per capita. They're not per cost per case. The reason we did this is we then compared these to the current health budgets in these different countries, and clearly, as you can see in some of the countries, particularly sort of Karachi, Delhi, India, Pakistan, these levels of cost per capita are in line with current total levels of healthcare spend in those countries. On the right-hand side are the costs in terms of household costs, and I want to be very clear here, this was done from a microeconomic perspective. This was really looking at immediate productivity loss from cost of illness, and what we did is we took data. There's been various TB costing studies from different countries that have looked at costs of seeking care for respiratory symptoms and what happens when you have them. And essentially we adjusted that data to the age groups and the different groups affected by COVID to make these estimates. So this is not, again, new primary data collection. This is taking existing data and trying to make the best assumptions onto how what the cost of COVID could be in the different settings. So that gives you some idea. And again, this is cost of illness. This is not cost of mitigation. So this is not costs of isolating or quarantine or not working. We also, not working, this is not working because of illness rather than not working because of the intervention. We also looked at the costs over time, and here in millions of dollars, and this is obviously more detailed figures to help countries plan. So these are the different costs over time. Just hold there for a moment. Okay, so now I want to reflect on some of the key methods challenges that I'm sure others who are working in this area are facing as well, and hopefully we can have a good discussion following the presentation. I think one of the things we've struggled with is how to link to epidemiological models and the uncertainty within them and the uncertainty around COVID. We've also had many sort of internal debates on how we address perspective. I think most of us are used to using just a provider-only perspective. We have commonly in TB used a societal perspective, but feel that it's also inadequate in this situation, or at least the limited societal perspective. And finally, what I want to spend most time on is how we can characterize what's happening in the real world. So going beyond this scenario, but trying to understand better and reflecting the costs incurred in the real world. Just linking to epidemiological models, and a note, and I realize my text might appear quite small here, although it does on my screen. First of all, there are many sources. If you are an economist but you're not connected within your institution or partnered with epidemiologists, as I'm sure many aren't, both Imperial and the London School and other organisations have developed apps and tools to help estimate cases from different scenarios. I give one example here. This is from the London School, which provides a series of scenarios and an app and country reports to explore different epidemic paths. So if you don't have access to your own set of modelers, these are very blunt, and there are many caveats which you will read on our site too, but nevertheless allow you to get some sense of different scenarios of different policies. I underline scenarios, not predictions. I think, as I hope you're all aware, as soon as we make a prediction for COVID, it changes because the policy response changes. So what this tool and what many of the modelling efforts are doing out there is not so much fitting day to day to the reality of COVID, but they're trying to explore, using what they know, how different policy options may work from now on in, which is different than actually making clear predictions. So they're more to explore different policy decisions rather than say, well, tomorrow it's going to look like this. In the same way, my costs are not saying these are the real costs tomorrow or even the week after. So it's very, there are a couple of things uncertainties which are critical to costing. So from the health sector side, as I say, at the moment, understanding how costs change by the different stage and severity of illness, we have very little information on them. You will see over time, and if you're doing this work, you must sort of stay in touch with the emerging evidence on comorbidities and patterns of severity. The other thing is you should be aware, if you don't have directly integrated models with epi models, that you will avoid you won't be able to capture some of the feedbacks, and that may bias your results. For example, you won't be able to simultaneously capture adherence to interventions, which may change if very high costs are incurred by households, and then feed that back into the epidemiological model. So this kind of transfer of epi results to costing can be done, but just to be aware of some of the limitations. Just briefly talking about perspective, I think if people are familiar, and I think there was a presentation by Richard Smith for iHEA a few months ago, very clearly explaining why for pandemics a macroeconomic perspective may be the most appropriate, and I think we're all living and understanding that is indeed the case. But I do think even if you're not, if economists, microeconomists or economic evaluators or health economists do not have access to macroeconomic models, it's at least important to include household cost data. We've had a lot of back and forth to say, do we actually restrict the policy scenarios that we model if we're not able to model the macroeconomic consequences, and feel now reluctant to model scenarios such as lockdown unless we can capture those broader impacts, and because we're worried about presenting or results that can be used in a misleading way. So I think that's something important to consider. The other thing we're thinking about, and some of you will be aware of the second panel, the US second panel recommendations on societal perspectives and the inventories, it would be useful, and we hope to develop in the coming weeks an equivalent inventory for COVID. Okay, I'm just going to leave a moment for the interpreter to catch up with that. I started speaking too quickly. Okay, so the last part of my talk, the last 5 minutes, I just want to talk about how we deal with capacity and how capacity and the real world can affect our costing. So this is some work on the right-hand side. This is not COVID. This is from TB, and this was a model we did a couple of years ago that examined the impact or how human resource constraints are likely to affect TB intervention. So on the bottom, we had a list of case-finding interventions, and each of the bars going from dark to light showed the impact we have if human resources and other constraints are there. So the dark bars are the reductions in incidence if we have an unconstrained epidemic response, and the white bars are showing what happens when you're constrained. And we applied that to an economic evaluation model to show how our cost effectiveness ratios change from when you have an unconstrained scenario versus a constrained scenario, that either you have to cost to relieve those constraints or you have much less impact for the money you're spending, so your cost effectiveness ratios increase. I think we've struggled with the same issue in COVID. Are we going to what extent can we relieve the capacity and actually expand capacity with our costs compared to actually accept that we are going to have less of an impact on survival within our existing constraints? And fundamentally, that's where you set that bar, and how you set that bar by understanding your current capacity will affect your costs. It's a decision you have to make up front. We're working on this now, expanding that early work we've done, and we're looking at different examples or options and a kind of, if you like, a pathway model, like we've seen in many also capacity models. So here's an example of the WHO recommendations, the nurse-patient ratios, the things which should be available. Then if we move to this, we have the costs of those different options, which are the ones that that you see have driven our other model. So this is the costs of the sort of WHO scenarios. I'm slowing again just to give time for the interpreter to catch up. So then we started to think about how capacity could constrain the different elements of that system. So together with clinicians, and we're working with people in each of the countries, we're trying to understand how, if there's a restriction, the one you saw earlier, of healthcare workers, what starts to happen to the nurse-patient ratio. We start to understand if different kinds of beds are available, whether it's general admissions or ICU care, what starts to happen to the way people are treated. And we begin to draw this kind of diagram and understand how cost but also survival may change as capacity changes. And here we have some very early results. These were just actually finished today, so I just put a caveat by them that these are probably going to be revised, but it's more to give an example of what you have to do as you move away from sort of an unmitigated but perfect response scenario of costing. And you can see that the costs change substantially, but then as we're beginning to work out in a more typical economic evaluation fashion, there is obviously an incremental cost per death averted and eventually DALY averted using this kind of pathway model. And I think not just us, but I understand that several other groups are developing similar kinds of models. And I hope in the next few weeks, as some of the countries unfortunately may be already breaching and going over the current bed capacity, that we get a better understanding of how that capacity should be enhanced or dealt with. I'm almost at the end there. I mean, for those of you who are doing this, and I'm happy, we're trying to expand our communication on this. There are a myriad of different assumptions, minor detailed assumptions, which make large differences to costs going on behind these kind of models. How people actually use PPE in the real world, as I've talked about, how healthcare workers respond to capacity constraints. I'm sure all of you involved in this area have had long conversations and learning a lot about different methods of oxygen supply and how they're used and how many litres are given for what type of patients. And length of stay remains a critical data item that we have very little understanding of how it changes during the epidemic. We see in some countries at early stages long length of stays as they learn how to treat patients and also keep patients in for confirmatory tests. That then reduces over time and reduces further as capacity gets constrained. And again, another critical detail, obviously we don't have much data at the moment of survival when people are not receiving different bits of care, and that is a critical area of data that we're missing. So I'm going to stop now, I think, with a final plea. I do hope this seminar helps motivate people to get involved in what may seem quite boring work in terms of cost in the epidemic and thinking about economic evaluation, or even if people are saying this is not an issue, to still get involved. I think our community has a lot to say to move away from dichotomized policy choices, but really try and inform with realistic responses at the health sector level, and find the language to engage with it, not just being the modelers or the macroeconomists, but also those of us who are used to understanding health systems constraints and working within the health system to be part of the policy discussion. I've identified, even if health economists are working in institutions which don't have access to the various complex forms of modelling out there, there's huge data needs that can go into those models and can really help improve the accuracy of modelling different policy scenarios. And just to encourage people as they're doing so to sort of jump, if you like, into the field of preprints and open sharing. And we are trying, there's a blank website at the moment, but I still put it here just in case people are looking at this in the weeks to come. We're in the process of setting up a website, at least where we can begin to informally share tools and data. And I'd like to thank all those, Wellcome and UK Aid who funded this work. But in fact, much of this work was done before we received any funding for it, and it has been people's evenings and nights, and as many of us are doing at the moment. So I also want to thank all those who spent that time trying to figure out very detailed things such as oxygen costs at midnight. So thank you all, and now back over to you, Cara, for the questions.
Much, Anna, and that was really interesting, and it's been really interesting to watch some of the questions and comments as they come up on the chat. So I'm going to see if I can, I think what I'll do is I'll ask you 3 questions that have come up. So if you've got a pen, Anna, you can keep track of them, and then we'll come back for some more. So the first question that a couple of people have asked is what's driving the difference across the cities? So in particular, why is Johannesburg in South Africa so much more why is the epidemic unmitigated so much more costly there? And is that kind of driven by the underlying costs of the health system? The second question is about kind of the use of TB as your kind of exemplar. So clearly there are some similarities with TB as a respiratory illness, but it's also kind of a longer term, more chronic disease. So I wonder if you could just tell us something about why, is it more than just that that's the disease area that you have lots of data on? And then the third question for now is could you say a little bit more about the data sources? So you've said that you're getting data from a variety of sources. I wonder if you could comment on where you're gathering your data from to populate your model. Back over to you, Anna.
Thank you. Okay, the assumptions we're making about comorbidity. So the extent of severe disease within the population now, as I said, I think that we have a lot of uncertainty about that. You can see in those sort of pink graphs how much that is driving our cost estimates in terms of bed day needs and healthcare worker needs. That's not between countries, but just to say that that also applies between countries. You can see the difference also within countries. So that's on the epidemiological side. But you're right, on the sort of in terms of South Africa, it is because the unit costs we are using are so much higher, and not only that, because of the income levels of the population who we think will be affected are so much higher. So both on the health system and household cost size. To be frank, the reason we used TB to start with, in fact, that was almost our motive. It was almost a topsy-turvy motivation to start that. I think when we started, as I say, a number of months ago, it was more, I'm sure as many institutions, you look at your own data sets and you say, well, I can't sort of collect any more data, but how can I rapidly use what I've got to help this situation? So I would say the first instinct was because that's where we had the data, and also we know the data. But we did have to adjust the data, and we did ask ourselves critically how relevant is this to COVID? So particularly around the income losses, you're right, that's a long-term illness. We are lucky that we have data sets that follow cohorts of TB patients. So we were careful about what period during TB we estimated income loss. So we tried to estimate income loss for the period when people were symptomatic, but not longer term income loss, and also taking into account, so we have a model that we'd actually used previously to adjust from smaller settings to nationwide estimates. So we essentially used a very similar model. So it was partly adjusting the length, but also, as I say, age structure, but also income level. So we did quite a few adjustments, and that is, I think we didn't just take that value and multiply it by the number of cases, because I agree very much that it's overall as a disease, it has a different long-term cost. Data sources, so there's a huge, I mean, we some systematically and some less systematically, to be honest. So we used our existing data. We relied on two systematic reviews, previous reviews for ICU bed capacity. We relied on WHO data, World Bank data on other areas of capacity, such as beds and healthcare workers. We searched for individual cost studies on PubMed quick, not, I mean, as systematic as we could, but not anywhere near a proper systematic review for things like ICU. We referred to a lot of the pneumonia literature to also compare our costs. And as I say, we also were in contact with groups that we were, part of the reason we chose the countries and sites we did is that they were also, many of them, part of the Value TB study. So we worked with researchers in each of those countries to also get additional data items. Actually, the report is pre-printed, and we have about a 10-page technical appendix. You can see the mishmash of different data sources we used to get these estimates out quickly. And actually, we're currently rewriting that as well with additional data sources. So I'm happy. I don't know quite with the organisers to send those links out to people who are attending this as well. Cara, I think, sorry, back over to you, Cara. Hopefully I answered those questions.
So I want to take you just to one very specific question that Jason Ong asked. And I think when I hand back over to you, you might flip up to the slide that has the numbers. So Jason's question was, how come costs are reduced when there's reduced staff and ICU capacity? Isn't that, shouldn't costs increase as more people get sicker or die? Or is it because it's cheaper when more people are dying? So Anna, when I hand back to you, can you flip up to that slide? Unless I can. I don't think I can. So if you could flip back up to that slide and then respond to Jason's question in the chat, and then you could hand back over to me for some more questions.
Okay, with the slide, I think you were probably, I'm just trying to understand which slide you were talking about, but here this is not so much the cost, but it's the resource needs, depending on whether ICU in a surge or a no surge, which I think is the part that you were referring to. I'm just checking here because I think we only present one here. You're exactly right. We assumed, post discussion, but you can see it's different in different settings, both in terms of healthcare workers, but also bed needs. We discussed the shortest level of beds that you could have if there was a surge. And you're right, the outcomes, what I'm not presenting here are deaths, and I'm not presenting here the consequential deaths associated with doing this. And obviously the last part would have a higher number of deaths because we'd assume treatment was shorter. And I think that's what again, I'm not quite sure which slide, but I'll just go here because this also illustrates it. So when we got here, I'm afraid on my screen this looks very small, but we were looking here that yes, you have a reduction in cost because you're using less staff and less ICU capacity, but and then you are there'll be more people dying. I don't want to say you're killing people by doing that, but more people will die as a consequence. So when we have an incremental cost per death averted, we're talking about if you manage to have full ICU and staffing, you would be able to save more lives by having this kind of cost at this level of deaths averted. And I'm just going to stop there for a moment so the interpreter can catch up. And I apologize to the interpreter, I'm speaking too fast. So Jason, what we obviously don't know is what is the impact on survival of not providing the full care or having shorter lengths of stay or less access to ICU. We did an initial consultation with experts saying, well, if someone needed this and they didn't get it, how would that affect their survival, to sort of parameterize our pathways. But this is literally happening in the last few days, so I don't want people to walk away with these figures and start using them in any policy environment. It's just to illustrate that that's what we need to do. I hope that makes sense.
Anna. Yes, Jason has said that makes sense. That's great. There's a few people asking for just a little bit more detail about the methodology. So, was your framing a top-down or a bottom-up? I wonder if you could just spend a minute or two just talking about how you started and what's the way that you're building up your costs. And then after that, there is a couple of questions about the broader cost and about interventions. Maybe I'll let you do the first, and then I'll come back and frame some of the other questions as well. Back to you, Anna.
Hi. Our primary motivation was to inform people planning and budgeting, and to perhaps at that moment already highlight that going along the way of following those guidelines in a perfect world may be unaffordable or present challenges. So in that sense, what we did is we took a bottom-up costing, a kind of ingredients budgetary approach. Having said that, the costs, if you like, of outpatient visits and inpatient bed days were taken from a bottom-up costing of the Value TB study, but those were not based on a specific guideline of how you cost an outpatient visit or an inpatient bed day. They were actually real world in terms of the resource usage we'd seen in those countries, but they were all bottom-up costs that you see here. Going forward, when we move to our more real-world estimates, then we may well reconsider that. On the other hand, part of the issue with top-down estimates is they incorporate current levels of inefficiency, and I would imagine during a surge, things would become much more efficient, so maybe they are less appropriate in this circumstance. Cara, sorry, over to you.
A couple of questions here that are about the kind of the boundaries of the analysis. So clearly, in this first crack at things, you're looking at the direct illness costs, but there's a few things in the news today here in the United Kingdom that make us think about the broader cost. So one is the indirect health impact of treatment that is foregone or delayed, and the other question, and whether it's possible to integrate those at some point. The news today was that we're expecting waiting lists of 10 million people by the end of the year for some fairly routine services. And then Stavros Petru from Oxford is asking whether we should be taking the boundaries even further and looking at things like the economic consequences of education losses, and sort of linked to that, a question of whether we have the right valuation tools to do that, and whether even the kind of macroeconomic approaches that are being taken now would be able to capture the costs of foregone education. So 2 questions there to you about boundaries, Anna.
Great. Our challenge as researchers is how do we present evidence and not just highlight these as issues as to the extent of displacement. I think some of you who are involved in infectious diseases are aware of the different modelling consortia. There is a wide range of work emerging from those different other disease areas talking about the specific impacts on those diseases. So recently there was a study published on TB looking at the consequences of, I think one of the things in TB is people have said, well, perhaps all these measures of social distancing will actually improve the situation in TB because it also will prevent TB, but those findings sort of suggest that actually the displacement of following up TB patients is much more damaging than actually the benefits from social distancing. There's other studies by Mark Jitt at the school who've looked at similar trade-offs around immunization, again highlighting that if services stop around immunization, the consequences. So this is clearly something that's happening, and it's how we begin to use the kind of, I mean, what we were thinking is using the pathway models that we're using to estimate costs of different COVID scenarios. We have information from various countries on the cost of essential packages, and somehow we have some specific ideas, but just in broad terms, bringing them together to look at different sort of optimal scenarios of what an essential non-COVID package of services that needs to be retained, which I know the WHO have been very clear about. and the essential, if you like, COVID or emergency and critical care pathways for COVID patients, and begin to use the kind of approaches we're using here to pull that together. But as you can imagine, a substantial piece of work. Aside from that, I think it's really important, like in the UK, that countries, and if you're health economists working in countries, that if you're able to collect data on what is happening to health services during the epidemic or pandemic, that data should be, if we can, be collected by health economists and published as it's happening. So that's the first question on displacement. Stavros, I'm not a macroeconomic modeler. I work with two macroeconomic modelers at the school, but my understanding is currently the kind of CGE models that they're using, and this is something we also are discussing, estimate annual impact and not long-term impacts. I think, as far as I understand, within the macroeconomic community, there is a suggestion that different types of modelling approaches are used, those with climate change looking at longer term impacts, and I agree. The frame we're using in the current to make sort of macroeconomic projections which governments can rely on in the short term to plan their finances they're not capturing the eventual long-term costs, but also potential benefits of the COVID, well, very few, but at least some of the COVID response. And I think that's a important research gap. I think the thing that bothers me about that is we're making, I suppose the thing why I think it's urgent to do that and not as just a nice afterthought, is we are making decisions based on the short term now. And I think now we're a few months in, we need to be balancing short, and even if our estimates are very uncertain in the medium term for health systems or for the macroeconomy, I think it would serve policymakers if at least we can include them in the trade-offs we're discussing. So, Cara, I'll stop there. That was quite a long answer, but important questions. Cara, over to you. I'm sorry, Cara, I can't hear you. I don't know if people can hear me. Don't know if someone could put in the chat box. Oh, you can hear me. So I can try. I think I've lost Cara. I'm not sure if Nicole, you need to switch. Nicole, if you need to switch to Cara being the presenter again. I'm just going to go up the chat box a bit myself to see if I can see any questions. Nicole, are you able to switch to Cara? I'm sorry, I'm just trying to click up the chat box, see if I can answer anyone else's while we're waiting. So we have non-COVID. I think I've got that one. Apologies, everyone. Yeah, Jason, just on your comment, those, by the way, the table you see there, Jason, they are only health service costs, just to be clear on this, so that also helps answer your question. Cara, you're here again.
Okay, is that over to me now? I think it might. Yes, I'm the active presenter. Great. Thanks for those answers, Anna. Sorry, we're not so slick and moving between us. Somebody also asked about whether there's a framework for non-pharmaceutical interventions and doing cost-effectiveness analysis. So I guess for some of us who do a little bit of cost-effectiveness analysis, it feels to me like we're often not using pharmaceutical interventions only, but that terminology of NPIs has been used specifically in COVID. So I wonder, Anna, can you say something about whether the framework is any different for NPIs than it is for any of the existing sorts of interventions that you would eventually be modeling the cost effectiveness of using these data as the starting point?
Yes, well, choice MPIs, but we are currently looking at that. I think it comes back, first of all, it comes back to my question that if we are modelling some of those interventions, and if you're keeping to a very restricted frame of health system costs and immediate household impact in terms of looking at the costs of, say, not attending work for X number of days and not having access to the macroeconomic impact, you may give misleading results. I mean, I think the ideal framework is a macroeconomic framework for this. Having said this, we have decided within a limit, so not complete lockdown, but within a limited number of scenarios, to, within a microeconomic model, look at health sector costs and immediate health impact. And the reason we're doing that is, at the moment with the macro, we think as much as the overall impact is important, what's really important is what COVID is doing to poor and vulnerable groups. And using a microeconomic framework is allowing us in a very, very limited way to try and sort of unpick, if you like, in more detailed differences between different social economic strata. So I think ideally you want a macroeconomic framework. You don't want a framework that's just producing GDP results. It should be producing economic, sort of overall economic welfare results, productivity results, health impact, and looking at how those impacts are spread or distributed against amongst different population groups. And that's the ideal. But if you can't, I think it's still acceptable for some scenarios to use more limited frameworks, but be very clear when results are being presented on how limited they are, and perhaps the more extreme scenarios leave to those who can fully capture all the negative economic consequences of those. Sorry, Carl, to you.
So there's a question from Pankaj, who says, I'm curious to know, how did we account for the increase in COVID mortality when we reached the breaching point in terms of health system capacity? So more deaths would be expected when the system is overwhelmed and unable to treat them. What's the impact of this on the cost? At this point, augmenting the capacity will have a greater marginal cost. Is this the case? Back over to you, Anna.
Yeah, so in the first instance, just running these two very blunt scenarios of what we think would happen to length of stay based on, as I say, a particular peak. What we're doing now is really trying to, and this is a sort of pictorial representation, but it's sort of underneath, it's in the end, it's a Markov model that's very similar to the models we're used to using in economic evaluation, but one that can be constrained by capacity constraints, and really trying to understand when you do hit that capacity, what happens if you, you'll first hit your nurse capacity, what happens to survival if you don't have enough nurses, what happens to capacity if you don't have access to oxygen, what happens to capacity if you don't have access, if you sort of breach your intensive care activity. And we are trying to better understand that, working with experts in essential and clinical care to come up with models that are optimal within a very limited, different levels of constraints within health systems. So my answer is I don't have a neat result for you now of saying exactly what would happen in different settings, but what we're doing is playing around with different scenarios. And the slide here begun, sorry, I have an error on mine. I'm not sure if you can still hear me, but I think it's because it's ended, maybe. We've run out of time. I don't know if anyone's on the chat box. Oh no, you can still hear me. I got this unexpected error. Sorry. So anyway, but I can't click on to the next slide now. It's blocked. But But that's what we were beginning to try and explore in the next slide, is how many extra deaths you get once your capacity is constrained, assuming that people are using capacities in different ways. I hope that's clear.
And Anna, I'm so grateful to you for this really excellent presentation. I'm sure all the participants are as well. And thank you, those who have been sending in your questions and comments. It's been really a very, very stimulating and exciting exchange of ideas. Anna, we're really excited that you and your team are coming up with these ways of characterizing this problem. It's clearly an essential first step towards beginning to understand the full extent of the priorities and how to move forward in this challenging time. So thank you very much to everyone. And just to confirm that the recording of the webinar will be put up onto the iHEA website as soon as we can. And maybe we could add there some information about how to get in touch with Anna and her team if you're doing linked work as well. So thanks all very much, and thanks to iHEA for organizing.